Okay, there we go. The Three Stooges are on the screen on Facebook, and we are here. So, if you're here in the room, welcome. Good afternoon. Thank you very much for joining us. If you're here in Facebook, good afternoon, good morning, good evening, wherever you are in the world. We don't have one superstar for you today. We have two superstars from the world of hepatology, and in particular with their symptom focused, patient centric, and patient driven approach to PBC. So, Dave Jones, we all know and love from many, many years. So, Dave, I'm going to come to you first and say welcome and thank you very much for joining us.
Well, thank you, and it's a real pleasure. And to the next of these, and you're all probably out there thinking, who is this impossibly young and handsome-looking individual? And the answer, that's Robert. You know him already. That's British irony for you. But it's a real pleasure to introduce an old friend of mine and the newest medical advisor to the PBC Foundation, which we're delighted that Andreas has agreed to do. So Andreas Kremer, who is now in Zurich, was previously in Erlangen in Germany, and then before that with Ulrich in Amsterdam. So his main area of interest has been around itch in PBC, and he is genuinely the world leader in the study of that, shares with myself and colleagues real interest in the patient experience and symptoms and how we treat it, but is an out-and-out PBC expert. And this is his first Q&A session, and we thought we'd do it as a sort of, and for the I don't know if this translates to Switzerland, but this is a bit like Dragon's Den. You get two dragons for the price of one here, which is really good value for money. So we're going to do this as a bit of a double act, but it's just great to welcome Andreas and thank him for joining the broader PBC community, the PBC Foundation community, and also the weird and wonderful world of the Thursday afternoon Q&A sessions. Andreas, welcome.
Dave and Robert, thank you so much. I really feel honored to be part of this famous Q&A session, I have to say. I was told that this is really the PBC Q&A session worldwide, and it's a real pleasure to be part of that today for the first time. And yeah, I'm happy and looking forward to discussing with you online and on Facebook your thoughts, questions, comments, and happy to take them.
Wonderful.
And just as a format, what happens is that Robert asks some questions. I give very long-winded answers. Then Robert says, can we do a quick fire round when I give some very long-winded answers? And he gets sort of increasingly demanding that my answers are shorter. So you're here to be a sensible counterpoint to that.
So the good news is that today I'm not the one that has to shoot off early for a transplant meeting. So so hopefully we'll keep the answers nice and short. If you're in Facebook, or even if you're here in the room and click meeting, by way of introduction to Andreas, just if you have any questions, please do ask them. And if you want to share with us the country in which you are watching or in which you reside, that would be great as well, just to give Andreas an idea of what we do here. Right, so we're going to start with the questions. Now, do bear in mind that what we're doing here today, we're not giving you medical advice. What we're trying to do is give you medical information, and hopefully that medical information will be used to drive forward the conversations that you have with your own clinicians and help you get to the care and treatments that you need to help you live your life with PBC. So on that note, let's start with Ursa deoxycolic acid. What's it made of? Is it synthetic? Who wants to take this one?
Shall I take that one first?
Sure.
So I think behind this is a question I've been asked a few times, which is the history of Ursa deoxycolic acid and where it comes from. And for those of you who've had the benefit of a classical education, it includes the word Ursa, which is the Latin for bear. And Ursa deoxycolic acid is a bile acid, so it's in the bile acid pool. It's there normally in all species, but it is particularly present at high levels in bears. And somewhere deep in the history of all of this is a link to Chinese traditional medicine and bear bile. And I used to tell people this story, and it upset a lady in clinic once who thought that it was still made from bears, and it isn't. It's largely made, almost entirely made in a factory in Germany, and no bears are involved in it at all. I think that's just important to say. So it's a bile acid. We produce bile acids normally. They're there to go, they're drained out the bile, produced by the liver, and they are there in nature to help you dissolve fat, because fat in your diet is insoluble. And so your body can't absorb it unless it's made soluble. So bile acids, in a sense, are detergents. They're like washing powder, that they what's called emulsify fat. They make it soluble, and that's what bile acids are there to do. What on earth has this got to do with PBC? Well, we think that what happens is, because your bile doesn't flow particularly effectively in PBC, you get narrowing of the bile ducts, bile builds up, and in its natural form in humans, it can be irritant. And it's the irritant properties of bile acids that cause a number of the features of the disease. And basically, there are, depending on the chemical composition, some bile acids that are irritant to humans and some that aren't. And Ursa deoxycolic acid is a type that is non-irritant in the nature of its own structure. And by taking Ursa tablets, you essentially replace your body's production of more irritant ones with a non-irritant one. So it creates a much more sympathetic bile acid pool. It damps down a lot of the inflammation. And this is why, if you take it over a long period of time, you can get a percentage of bile acids in your bile acid pool up to 60 or 70% Ursa deoxycholic acid. That's how it works. But no bears are harmed in the making of it, and it is made largely in a factory in Germany. But it is a natural thing that is made synthetically when we give it as a tablet. The equivalent is something like thyroxine that many people are familiar with. So it's something our body naturally produces, but we give in additional tablet form. So that's Ursa deoxycholic acid.
Perfect. Thank you.
If I may add here, I always tend to tell my patients it's not a drug. It's a substance which you have already in your body. So it's rather a supplementation of something your body already can produce, but albeit only in very limited amounts. And this is something we enrich.
Yes, it's almost like a vitamin in that regard, actually, which is vitamins are things that your body needs to have naturally, but struggles to produce enough.
Okay, perfect. Thank you both. Okay, next question. Do PBC patients come under the term immunosuppressed or have a suppressed immune system?
Shall I take that question?
Yeah,
no, it's not immunosuppression in PBC. It's rather the opposite. It's rather a too active immune system. So the immune system recognizes some structures in the bile duct system as foreign and attacks these bile duct structures. And this causes inflammation and damage in this bile duct tree. It looks like a tree without leaves, actually. And the smallest branches are attacked in PBC. And despite the fact that the immune system is somewhat too active in PBC regarding these small and smallest bile ducts, drugs which are immunosuppressive lack efficacy in this disease. It's different to other immune-mediated or autoimmune diseases where we can give steroids, cortisone, and others to calm down the immune system. If we do that in PBC, it's without benefit for the liver. So there is an immune-mediated disease. It has nothing to do with immunosuppression, and we don't need immunosuppressive diseases, drugs to treat that. Ursa deoxycholic acid, as mentioned, this bile acid improves this situation. And all drugs which are licensed or used as off-label are not influencing the immune system or or calming down the immune system.
Can I ask, Andreas, I suspect behind that question is one that's cropped up a lot, which is about COVID risk. So as you might imagine, the whole of the history
That's a good point,
yeah, the whole of the history of the Q&A sessions was they started early in COVID as a way of keeping people informed. And so it's been a question about the risks of COVID and the risks and benefits of vaccination has cropped up a lot. So what I thought was really interesting, and I suspect in that question, are people immunocompromised and therefore potentially at risk of COVID? I'm just really interested. What was your experience of PBC and COVID?
Well, we have not observed any increased risk. We have no data that, or clear data that, UDCA treatment has a strong benefit here. But interestingly, and this is high rank published, UDCA has a benefit in, the viral entry into the biliary cells. To which extent that is really the case in a, let's say, mild to moderate SARS-CoV-2 infection is questionable, because the viremia is normally only seen in these very advanced or in infections.
Yeah.
But still, I think there is data out there suggesting that you may use UDCA to modulate, let's say, or to positively influence SARS-CoV-2 infections. And in that regard, it would rather be the way that taking UDCA is beneficial if you get in contact with this virus, or if you may have suffered from COVID in the past. And this is maybe something our listeners may have experienced, that COVID infection, if it occurred, was rather a milder version, but there's very hard data is lacking, but there are very interesting insights into the pathophysiology of the viral, entry and so on with UDCA. So in that regard, UDCA is certainly not harmful if for a COVID infection.
I mean, I think that was interesting, because that was our experience, is that we were very concerned at the very outset that patients would be at risk, and it just didn't really pan out that way. And as you say, very little hard data, but other than people with advanced cirrhosis and people post-transplant who are different in this regard, there seemed to be much less in the way of risk from COVID than we might perhaps have expected. And I say, I was actually asked at a couple of these Q&A sessions, the week that paper on Ursa came out, I was asked what did I think about that data? So just be warned, this is a very knowledgeable audience who are interested in this and know a lot about it. But I think we tend to be increasingly reassuring with people that COVID has not been a particular problem, but we need to be cautious about it.
Yeah, that's ideal. So actually, believe it or not, I have a PhD student whose mother has PBC. So he's already a top grade bloke. But more seriously, he saw the research paper from Cambridge.
Yeah.
And so he wants to look for his PhD at looking at Ursa and COVID and PBC and all of those kind of things. So that'll be really interesting to see what comes there. And he'll be engaged in the app. He'll be looking to do a survey with us and all of that kind of thing, which again is absolute testament to the PBC community and their engagement in the answers.
Well, that's brilliant. And, I'm sure for all of the medical advisors that we would be absolutely delighted to collaborate on that, because I think information in this space is very, very valuable. My wife is an intensive care consultant and therefore saw, the hard end of COVID, if you like. And what she tells me is that there is a group of people who are particularly badly affected by COVID, and those are people with blood cancers, so various different forms of chronic leukemia. And part of the problem with those people is that they don't respond to the vaccine. So the people that you most want to protect are the ones who are least likely to respond to the vaccine. And she was really interested in the Ursa data, because this idea that in a high-risk group who do have high levels of viremia, the idea that an entirely different mechanism would didn't rely on the immune system might potentially protect them, I think is a very, very interesting one. And the networking of all of this is that actually the people who make Ursa weren't aware of it. So we networked into the company who are now looking at the potential values of Ursa with that. And I think therefore these networks are very important. But if I had a sort of chronic leukemia and wasn't responding to the vaccine, I'd be really interested in taking Ursa.
Right. Okay. All right. Thank you. So on the subject of please, Andreas.
Sorry. I fully agree, and I think it would be great to have data on treating that in combination with, for example, existing other drugs which are available, and direct acting antivirals or antibody treatment, as an additive, because it's very safe UDCA. You can just take it. It's a substance from your body, and so this makes it so much more attractive. On top of that, we have all the safety data. It wouldn't interact with any other drugs. I think in that regard, it's really ideal. From the perspective of the validity of the data, it would be very interesting to, in particular, ask PBC patients with advanced fibrosis or cirrhosis, how was their course of the disease if they were infected? That would be the most interesting subgroup in that regard, because those are patients at risk. The more the liver disease is advanced, the highest was the risk. So this would be the subpopulation which would be most interesting to be investigated in that PhD.
Okay. Yeah. Brilliant. Okay. Watch this space. Okay, so background, we've got somebody who's been diagnosed now, as well as their PBC, they have kidney disease, Crohn's, peripheral artery disease, spinal stenosis, and microvascular angina. So, with all that in mind, it's been on Ursa since January, painful urination, similar to cystitis, but not quite the same. Sharp pain in the right side of the tummy button. Thirst is increased. Appetite has decreased. Losing weight and whiteheads around her lips. And she's just really concerned that any of that could be down to Ursa. Any thoughts, please, gents?
I'll crack on with that one. No would be my simple answer. It's really difficult where people have complex health problems. One of the challenges that we all encounter as clinicians is the tendency for people, mainly other clinicians, to put everything down to one of the other conditions. So it's one of the dangers that we talk about here, which is that I think the worst example was a lady I came across who had stage 1 PBC and sadly developed breast cancer and was told that she couldn't have chemotherapy for her breast cancer because she had stage 1 PBC. So it's really important to try and work out what causes what impacts on what, but you do need to see people in the whole. So, for example, where people have got inflammatory bowel disease like Crohn's disease or rheumatoid arthritis or things like that, thinking about the therapy you might give for those drugs in the context of PBC is very important. So there are some drugs that might be useful for both, and there are some drugs that might be useful for the other condition where you wouldn't want to use them in PBC. So it's trying to find a sympathetic combination is very important. So it's very important your clinicians all talk to each other. Renal disease creates its own issues, and it does two things in people with PBC. We don't see any renal disease particularly associated with PBC, but of course PBC doesn't stop you having conditions for other reasons. But chronic renal disease has two impacts. One is it can impact how your body handles drugs. You need to be very careful about which drugs you take, although not interestingly Ursa, it doesn't particularly have an impact there. But the other one is, of course, that renal disease causes both fatigue and itch if it's in a bad form. And so you need to be aware that it can combine with the PBC related things. So are those problems down to Ursa? So my gut feeling, I'll get Andreas's comment in a second, is no. What Ursa can do is it can cause you to get GI disturbance. So it can cause you to get some sickliness and some alteration of the bowel habit. Sometimes people get gripey abdominal pain. So the pain around the tummy button is the only thing that might conceivably be linked to that. Many people report it causes some hair loss. I could have taken a lot of Ursa, but haven't. I just lost my hair. So there can be some hair thinning, which is an issue. But other than that, it's pretty straightforward. And because it goes back to Andreas's comment that this is something that our bodies produce naturally. And so therefore, when it's a natural thing, it tends not to have many in the way of side effects. So my gut feeling is no in this situation. If you really think that problems are coming from Ursa, and remember, just occasionally, if you've changed the brand, and again, something we've talked about quite a lot is generics. So, there are what are called branded medicines, so Ursa Folk that people are very familiar with. But a lot of Ursa is generic. It's made by different companies at different times to slightly different formulae. And the coverings and the colorings and things can be different. And sometimes people can react to those. So if people, time-wise, it really, really feels like it's the Ursa that's caused a problem, then a little period of time without it to find out if those problems go away is the right way to do it. But if you've been on Ursa for a long period of time and new problems arise, it's very unlikely to be the Ursa. Do you want to add anything to that, Andreas?
No, you have explained that very well. I would fully agree. And I would rather, if you have these, cystitis-like symptoms, you have to check urine, you have to do a sonography and so on. And I would not think that UDCA is the cause of that particular symptom burden.
All right, perfect. Thank you. Okay. So on the subject of symptom burden, Andreas, I'll come to you first, if I may. So it says, recently the tops of my feet and the tips of my toes have started itching during the night. Other isolated parts itch occasionally, e.g. my knee, forearm, back of my neck, left-hand side. I put this down to perhaps being too warm in bed, but could this be caused by PBC?
Yes, I think in particular the location, the soles of the feet, that could be, of course, also the tip of a toe or the palms of the hands. If the skin looks normal, if there is no eczema or, obviously alterations, reddish areas or very dry skin, then I would say these are predilection sites of pruritus in PBC. So despite the liver being, sick, it's the skin which gives you a symptom. This is, of course, at first sight pretty strange, because we have learned that rather mosquito bite or a stinging nettle causes an itch on our skin and not a liver disease or a kidney disease. But interestingly, we have understood that certain internal disorders cause an itch. We do not fully understand the pathophysiology, meaning which signaling molecule causes this itch. But research is ongoing, and indeed, I would think this could well be PBC-related itching. And from the predilection side and also the time course, typically when patients in the later evening or early at night go to bed, then they report that itch is most intense. And that would, if it's mild to moderate, result in my question, do you want to have it treated? You could start with a topical treatment if it's mild and so far tolerable. If it's not well tolerated, if sleep is disturbed, then we should think of going a little bit beyond the topical treatment.
I mean, I just agree with that completely. And there's some work that Andreas and I are both involved with, which is related to some of the work around the new IBAT inhibitors, the new types of drugs that have been on trial. And what this shows is that there is a really strong association between bad itch and poor sleep. A really, really strong association. We've suspected that for a long period of time from what people tell us in the clinic. And of course, poor sleep is then associated with lots of other problems, fatigue the following day. People get very run down with it, mood problems. So itch is really important as a cause of sort of skin irritation, but it has a knock-on draining effect on people. And it really is a very important thing to think about with treatment. And Andreas alluded to this. The question that we always ask people in the clinic is not, have you got itch? Because they will say yes or no. But some of the people who say yes, it's kind of a mild problem. The question is, have you got symptoms? Is the itch bad enough for us to want to treat it? And I think, but just remember that sometimes the sleep disturbance is more marked than the itch severity feels like it ought to be. And it can be the way to unlocking other symptoms.
Okay, perfect. Thank you. On the subject of sleep, we've actually had a question about sleep, and it says for the past 6 months, been having sleep problems, averaging about 3 hours a night of sleep. They can get to sleep, but they don't stay asleep. They tried silent night. Nitol's not an option because they have low blood pressure already. So what can you suggest, if at all anything, to help secure a good night's sleep?
I can start with that. So my question would be, why is the patient waking up at night? So what makes her or him wake up? Is that pruritus? Is that itching? Is that, being, nervous? Do you have, the feeling that you have to move your legs? What is it? I would like to understand the reason why falling asleep, obviously, if I understood that correctly, works quite well, but then somehow early in the night or in the middle of the night, she or he wakes up. And I would like to better understand that to help the patient a little bit, because that would then be a reason to treat this symptom differently. And I think this is necessary. I would not stick directly to any kind of drug treatment or whatever. I would be very careful and cautious with that, because that can significantly worsen fatigue in the other hand. And there may be some physicians out there who easily prescribe some sleeping pills. So I would rather try to better understand that, and then try to, individualize a little bit my recommendation. I think what is important always when we talk about sleep is sleep hygiene. And what does that mean? That means that if you wake up at night and, of course, then you cannot sleep and so on, the next day you may be tired. And then during daytime you lay down and you try to recover a little bit, but this is rather a disadvantage. So the patient should rather try to really get a sleep hygiene where sleeping means this is the place where I sleep, where I don't do anything else, where I don't watch TV or whatever it is, so that the brain or our head has a little bit the feeling, okay, here is the place, this is the place where I'm relaxed, where I can sleep and no other influences disturbing whatever I have, and then really try to rather stay awake during daytime, not to lay down during daytime, because that could then result in the waking up process at night, because falling asleep obviously works, if I understood that or interpreted that correctly.
You did, yes.
And don't do that great British thing. I don't know if this happens in Switzerland, but in Britain, if you can't sleep, you wake up in the middle of the night, you go downstairs and make yourself a cup of tea, which of course is the worst thing you can imagine doing, because tea has got as much stimulant in it as coffee does. And it's a very British thing. I couldn't sleep there for a cup of tea, so don't do that. And for the younger people, Red Bull is just the same, if not a little bit worse.
Indeed.
Fully agree. And if I may add that, putting a strong light has the same effect to our brain, because that gives the brain the signal, oh, the sun comes up and the next day starts. So if we wake up, we should rather try to have very, limited light influence, because that makes us awake as well. If I have a bright light for 15 minutes, then the brain thinks the next day has started. So this also a little recommendation.
And everybody, everyone will be familiar with, you're going on holiday, early flight the next morning, and you lie awake at bed thinking, oh God, I need to go to sleep. I'm up early in the morning, and then half an hour later, I need to go to sleep. And that's an example of, if you concentrate on trying to sleep, you almost never will sleep. And that's easier said than done. But to try and, in a sense, not think about it and not do it. And just if you read for a little while before going to sleep and then naturally fall asleep, that's a healthy way to do it. It's the most important thing, if you can. I agree with the comments about light totally. Try not to focus on this, because that will have exactly the opposite effect to the one that you want to have. But itch, the two, in a sense, direct PBC type things that really impact on sleep are itch, as we've talked about. The other one is dry eyes. So obviously Sjögren's, the gritty eyes, if you blink, it sort of has an irritant effect. And so again, treating some of these symptoms can be an important way to do it. Generally speaking, avoid tablets to help you sleep if you can. What they do is they kind of make people think you're asleep, but your brain doesn't act like it's asleep. So they are not productive.
Yeah, no, absolutely. Thank you. I think, Andreas, you hit the nail on the head when you spoke about sleep hygiene.
Yeah.
And it's everything from light coming into the room. It's everything to include the blue light and the white light from your telephone screens or your tablet. It's the temperature of your room. If you sleep with your dog on the bed and you wake up like this, there's so many contributing factors that are not necessarily clinical. So again, if we at the foundation can help, give us a call, and we're more than happy just to talk that through with you. All right, thank you.
Very good. Yeah, Robert.
We have another question. So we have a couple of questions on the same vein. So I'll give you the background, and then I'll come to you with general questions. So first off, we have somebody who was negative for AMA. Their sister is positive. Now, the sister has been told by her consultant that she's now at end-stage liver disease, and a liver transplant is her only hope. And again, if you've written in with this question, we would love to speak with you and see how we can help in any way, shape, or form. The other person who's written in with a similar question is 62 years old, well, fit, active. Sister is 58 and suffered for MS. Late mother had PBC. So my sister and I are wondering if there's any clear evidence of the condition being hereditary and passing to daughters, etc. So really, the question is about the benefits of testing, the risks of testing, and what can people do to really reassure themselves and to find the information they need one way or another.
Shall I have a crack at that?
Sure.
Okay. So PBC is not an inherited condition. So, by inherited condition, you would think of something like cystic fibrosis or hemophilia, where it goes from generation to generation to generation. However, we're all very familiar with conditions that are commoner in some families than in other families. Okay, so we'll all know about families where there's a lot of cancer, families where there's a lot of heart disease, but there'll also be families where there's a lot of autoimmune disease. Okay, and the reason for that is this apparent paradox that it's not inherited, but there are families where you see a little bit more of it, which is that the characteristics of your immune system you inherit. So we're used to height being inherited from our parents. So you look at the parents of a child, you can predict from that the likely height they're going to be based on their gender and their parental height, because basically it's a soft characteristic that's inherited. So there isn't a height gene, but tall parents have taller children because there are lots of genes that impact on that. Now, you can't see the equivalent of height with the immune system, but it's there. So people have vigorous immune systems and people have more passive immune systems, and those tendencies tend to be inherited. And when I'm explaining this in the clinic, I talk to them about this is why there are no more Brontes anymore. Because the Bronte family, the famous sort of 19th century novelists, they all died of TB apart from one of them. And why did they die of TB? Because presumably in the family there was no capacity to fight TB, and it was all of them in the family, not because they were all exposed to it, because everyone in 19th century UK was exposed to TB. It was they lacked the immune response to be able to cover it. Now, of course, their next door neighbours who didn't all die of TB, they're all, their children's children's children are the ones, are people who are alive today. And so therefore it enriches an immune system that's very good at fighting infections. That's evolution in practice. And our population's been shaped by TB and by the Black Death and by all of those things, so that we are the offspring of the people who survived all of those things. And they survived all of those things because they have an immune system that was effective at getting rid of them. So therefore, there is a tendency for immune systems in general to be more vigorous as generations go by. And that's what happens with autoimmune disease. In bald terms, if you look at the risk, if you have PBC, what is the risk of your daughter getting PBC? Which is a very, very legitimate question. And the answer is that it's about 20-fold higher than if they didn't have a mother with PBC. Okay. And that sounds terrible. That sounds really high. But remember, the risk of PBC developing in any person per year is about 50 per million. Okay, 5 per 100,000, 50 per million. Okay, that's the risk of somebody in the ordinary population developing PBC. So a 20-fold increase actually makes the condition still very, very rare. And we have, over the years, seen lots of people very worried who are the daughters and sons or sisters of people with PBC. And we have the following discussion I'm going to outline to you. And if you decide to test, I've never in my experience ever found anybody who's got PBC. So there is an element of susceptibility to do with these ways in which your immune system is built, but it is an overall low risk. Now, would I suggest to my daughter that they got tested for PBC if I had PBC? And the starting point would be no, okay? Because on balance, it is very unlikely to be there. And if you've got no particular reason to think it might be there, other than you've got a family connection, then you run into the dangers of the impacts of having done the testing around insurance and things like that, or also false positives. If, however, I had abnormal liver blood tests or I had symptoms, there is a reason to think it might be there, then absolutely that's the point at which you would test it. So our approach is to explain to people what I've said. There is a small increase in risk, but the overall risk remains very low. So if you ever do have abnormal liver blood tests, pregnancy screening and whatever, or you develop fatigue or itch, then mention it, and that's the right point to test. The exception for that is where people have a mum who's had a liver transplant at 40, okay? Because they have every reason in the world to be really worried about this. And in those situations, if it's the right thing for the individual to be reassured they haven't got it, then that's the right thing for them. So it's never a hard and fast rule, but I explain all of this. But if you're going to go home and be terrified about the thought of PBC, then statistically it's very unlikely to be PBC, and I would recommend that you test people in that situation. If you are AMA positive, but your blood tests are otherwise normal, calm down. There's nothing worrying about that. There's nothing to be done. All you then do is have your blood tests checked every year. And if you do develop abnormal liver blood tests, then we would start people on Ursa without any investigations. One thing I say to people, you'll often say, my mother 20 years ago had really bad PBC, and I'm really worried I'm going the same way. The world has changed out of all recognition in terms of how we treat this and the way we go about it. So somebody who had real problems with PBC 20 years ago, that was the dark ages of PBC compared to where it is now. So now we have these whole range of step-up treatments. So the comparison is what would happen to that relative if they were diagnosed today. And we are all, and Andreas is on exactly the same page as we are, all of us are on exactly the same page. We never want to transplant another single person for PBC, not ever, if we can avoid it. And getting better treatments out into the people who need them is the way to avoid that. And early diagnosis will be important. So don't worry about family risk, be aware of it and test if it's the right thing to do. And if you do find features of PBC, don't worry, start therapy. And it is, if you start therapy now, the risk of going on to need transplant, if you have the disease diagnosed early, is very, very small indeed. And think of the world today, not the world how it was a few years ago. And I'm, unlike Andreas, I'm very old. And I started doing PBC management in 1991. So that was my first ever clinic, was 32 years ago. And I can tell you this disease has changed out of all recognition. And in those days, we used to see all the time people with the complications of cirrhosis and all of that, and we simply don't see that anymore, other than in people who are diagnosed late. So the problem has shifted, and I can't emphasize that enough. When you've lived through all of that, what PBC looked like without availability of treatment, it was a different world.
Yeah. No, that's ideal. Thank you. Andreas.
Dave, may I ask you, now you have a woman, she is, let's say, 50, and she has a daughter at an age of 10, and she wants to know if I should test my daughter, which may have the highest risk if you think about, family members. So when should I test her? What would I test her? Antibodies, AMA screening at an age of 20, or would you do that, or rather not? But I mean, this is the common situation. You have a woman, she has a family, she has children. When and whom to test with what laboratory parameter?
Okay, so really good question. So we actually were referred a 16-year-old this week, and who turned out to be AMA negative. The important thing here is that PBC is non-existent, or at very most incredibly rare, below the age of about 30. So we do see very, very small numbers of people in their 20s. We do see more of that, and I think that's because there's an awareness that it can occur in people's 20s, but I've never seen anybody below the age of 20 with PBC, okay? There are one or two cases that people record, but if you look at them in detail, they're unusual patterns of things. So this is vanishingly uncommon if it ever exists below the age of 20. That's important information.
Yeah,
I would never ever suggest screening, and by screening I mean doing an antibody test in somebody for whom there is no other indication, in anybody below the age at which they could make that decision for themselves. And a 10-year-old, I don't think it's fair at all, because they're not making their own decision. So I would suggest to anybody is forget this until they're over 16, when they can actually make their own decision about the pros and cons of all of this. And there is plenty of time. And even if you find somebody who's got PBC, at 16 to 20, it's going to be, by definition, be very early disease. So I always park it to the point at which people are old enough to make their own decision with the pros and cons.
Yeah.
I take your point completely, that you don't want to turn. I think some of those people who did very badly in the past had PBC younger than anybody appreciated, and you missed the opportunity to treat it. But I think you can take that too far the other way, and I certainly wouldn't do it. Remember, though, if that child had been found to have abnormal liver blood tests or was struggling with energy or something like that, then you've got a different reason. Then you're investigating an abnormality, and that's a whole different kettle of fish. Remember, and boy, do we know this about COVID. We know this about COVID, that a test done to screen an entirely well person behaves in a very different way to a test to diagnose a condition if you know somebody is at risk of it. So the problem with COVID testing is once you do it in entirely asymptomatic people, then the false positive rate, becomes a really important issue. And the danger, I have certainly seen people in the past who were investigated. They had no reason to be investigated. They had slightly unusual patterns. They had a liver biopsy. They bled from the liver biopsy, and it's a disaster. And there was no reason to do it. So you have to have a different index of suspicion. Just to say, I mean, for Andreas, if you know the news, there's a whole load of controversy in the UK about a whole load of WhatsApp messages between all our politicians about COVID. Just to say on the record, if my WhatsApp messages were ever read, all it would do is consist of funny pictures of my cats, because that's all I've got on WhatsApp. So I've got no dodgy messages at all. Just thought I'd say that. But COVID, screening, leave it until you're over 18, or do it because you have a clinically important reason.
Or a symptom or whatever it is. Fully agree.
One of the tricky ones about this is if you're AMA positive and you've got classic cholestatic itch, and I've undoubtedly seen people like that. And I think for me, abnormal liver biochemistry or clinical features very strongly suggestive of PBC, I would then have a discussion about whether you would treat with people. And certainly I've had the discussion with people. Mum's had a transplant at 40. They're AMA positive. They weren't AMA positive 2 years ago. You know, what am I waiting for? Why don't you give me Ursa, given that it works early? I've had that discussion. I've ended up treating people, but it's always been the right thing for that person as an individual, given their fears and concerns. It's not a blanket approach.
Okay, perfect. Can I come back to COVID, because we've had a follow-up question on Facebook. So somebody, April 2020, they stayed with their husband who was a cancer patient in a city hospital during the beginning of COVID and before their PBC cirrhosis diagnosis. They never got COVID. Do they think that this is because of the overactive immune system?
Well, yeah, that's a question which is not directly answerable. I think, you know, you can never be sure whether you may have had COVID. And, you know, the course of COVID may be, you know, may range from purely being asymptomatic or just like a very little flu, you know, what we would hardly recognize as a real infection, to those who, you know, have respiratory symptoms, you know, have to go into be treated by oxygen in the hospital up to a respiratory machine. So this is the full spectrum of the disease. And I've been, you know, responsible for the COVID ward at our university hospital in Erlangen, where I have seen all these spectra. And in the beginning, we had to have all patients in ward once they had a positive test, despite any kind of, you know, symptom burden or whatsoever. So we have had, you know, many skiers coming back from Austria, and they were all hospitalized because nobody knew what to do with them. So very funny situations with very healthy people lying around in your isolation ward, and they were wondering when they were allowed to go out again. And on the other hand, you had these older people who just, you know, had a deteriorative course of the disease. So that was the full spectrum. So you're never sure whether you've really had it or not. It's difficult to prove. I mean, there are antibodies you can quantify, you know, antibodies against structures of this virus, which is not, you know, this spike protein, but they may disappear. So you're even unsure if they are negative, whether you may have had it. I think when you're vaccinated, when you're boosted, you can be pretty relaxed in regard to the current situation.
Yeah,
no, it's interesting that so my sister, right in the very beginning, so this was a genuinely scary thing in, you know, March, April, May 2020. So my sister went skiing in the French Alps just at the point it hit the French Alps. And she was staying with her 2 sons and her husband in a small apartment, and the other 3 went down with bad COVID. And she, you know, nobody knew what it was at that point, and she looked after all of them. In retrospect, it was tested out and was COVID, and they were all isolated in this small apartment for a week together, and yet she never contracted it, and nor did she ever have antibodies to it. Now, partly that could be the weird and wonderful ways that people are and aren't susceptible to infections. The other, of course, is that women are much less susceptible to COVID than men are. So it is so all of the epidemiology suggests that men are more at risk than women for whatever reason. So it's the weird and wonderful thing about infections. I think if you've been exposed like that and didn't get it, then that is really good news for you. And I think you'll never know whether you would have done or wouldn't have done. But it would generally fit with what we observe, which is that we just haven't seen much of a problem with it. Certainly not nearly as much as we were worried we were going to see.
So, no, absolutely. So I'm aware of time, so I was going to go into the quick fire round.
Good luck.
Thank you. So, sorry, there was a glitch there. I was just about to go into the quick fire round.
Great.
Great.
So, we've got an amazing question. So again, Andreas, you were warned about this is an engaged and informed and an incredibly intelligent patient population. So here is your question, okay?
Okay.
Welcome, I'm going to say. What are your thoughts about the research on PBC with regard to the potential of antiretroviral drugs? There was a flurry of reports identifying persistent beta retrovirus in people with PBC. Any thoughts on those studies, and why are we not hearing more about that in either the UK or Australia?
Yeah. Now we can talk another hour about that, but I have to be very concise. We do not know the causing pathogen, whether this is cosmetics, whether this is bacteria, whether this is virals who are causing a molecular mimicry that activates somehow our immune system to attack now the biliary tree. Yes, this is interesting data, which is particularly coming from Canada. It needs researchers who believe on their hypothesis to investigate such an approach, but we are in a very preclinical status of the current knowledge. Is that fair enough? Dave, do you want to add a small short comment?
Very well. I don't do short comments. I mean, this is Robert, by the way. It's classic Robert. Is if he was going to ask you what's the meaning of life, he would do it in the quickfire round. So the answer is, in susceptible people, there is something that triggers this disease. As Andreas says, we don't know what that trigger is. The thing about retroviruses is that, again, I've been around long enough to see the same ideas come around again and again and again. So the idea that retroviruses, the viruses that integrate into your genome, trigger autoimmune disease, has been around for a long time and has been suggested in lots and lots of diseases. It certainly was suggested in Sjogren's, it was suggested in chronic fatigue syndrome and various different things like that. And none of those have stood the test of time. And there's a well-worn track of thinking that this is there, looking for those retroviruses, finding them, and then treating them, and then showing that that's not effective. And you think, well, if they're there, aren't they significant? Well, the answer is that we all have lots and lots of retroviruses all the time because they're very good viruses. They don't cause you any problems, and you pass them on to other people. So it's a really interesting idea. There is some evidence for it. For me, to go to the next step of giving people antiretroviral therapy, which is quite toxic therapy, is too big a step. Right. So it's an interesting idea. It's one that has a bit of history to it in other diseases of it not stacking up. But I think it's too soon to go to treating people with potentially, essentially HIV treatment, which is pretty toxic.
Okay, perfect. Thank you both. Next question, cholesterol. So we've had somebody who's had high cholesterol for 20 years now. They were diagnosed with PBC in 2019. They've never smoked. Diet is relatively healthy. They probably don't exercise enough, and they weigh 64 kilograms. High cholesterol, high triglycerides. So they're asking, is that reason to start taking statins? And if so, what dose is best, and what are the implications for PBC in terms of should they avoid at the same time as Ursa, or what can we give in general terms? So Andreas, I'll come to you first.
Yeah. Again, very short and concise. We typically see this hypercholesterolemia in PBC patients. Why? Because there is a specific lipoprotein X, which runs in the LDL fraction in this, let's say, bad cholesterol typically, but we cannot differentiate that in our typical lipid analyses. So that should not threaten us, that it's the bad cholesterol. Now, hypertriglyceridemia is not caused by that. That can be genetically. My question would be, is there really a cardiovascular risk factor, meaning hypertension, diabetes, smoking, and importantly, family history of cardiovascular events? If any of these questions, and it's not overweight here. If any of these questions is answered with a yes, I would check my cardiovascular risk, and then I would, with a cardiologist or a hepatologist who is experienced, and then I would treat it. Otherwise, I would rather not treat purely this lab parameter, because we should treat patients and symptoms, but not lab parameters.
Perfect. Dave?
Yeah, cardiac PBC probably doesn't protect you against heart disease, but nor does it predispose. Your cholesterol is artificially high, so you need to put it into the right context. I don't particularly have any problem using statins. The thing that I've mentioned several times on these calls before is that strangely PBC patients smoke more than the equivalent non-PBC population. So just watch out for that. So smoking is something that you can do. It is the most important single thing that you can do to control your cardiac risk, and it will also help with your osteoporosis while you're at it.
Perfect.
I mean, I don't mean start smoking, I mean stop smoking. Okay. Just to be clear.
Clarity is always good. So, Andreas, we've had people saying good morning from Alabama. We've had people saying good morning from Canada. So nice to see you join us. So we actually have a question from somebody who has PBC. They live in the US. Doctors have advised them not to consume red meat. They have never advised them to not drink fruit juices, and nor have they advised against carbohydrates. So the question is that they're slightly confused because there's a lot of information out there, but what can we tell them in terms of food and drink to take or to avoid when you have PBC?
Well, I always tend to say, to make it very short and precise, eat fruits, but don't drink them. Why? You can easily drink a glass of orange juice with your croissant or whatever you have then for the breakfast. But if you have the 4 oranges, if you eat them, out of which you have made normally the juice, you're full. You don't want to eat anything else. So eating is okay, but not drinking, because that is too much additive, calories, and in particular carbohydrates, fructose. So too much fructose intake is of course never good. We get a fatty liver and so on. But in principle, I don't have specific recommendations. I always say, a Mediterranean diet, that means, rather, unsaturated fats, olive oil is better than, butter, and so on. But if this is equalized, I don't have anything about red meat. It's always the amount of what you eat is in most cases a problem. But I don't have very specific recommendations. Eat that, don't eat that. You should not be too overweight, because any secondary damage to your liver, whether this is fat, whether this is alcohol, or whatever it is harming the PBC liver more intense than if that would not be present. So every second factor should be, limited, and that would be my recommendation.
Okay, thank you. Before I come to you, Dave, just one follow-up question, if I may. You said eat your fruit, don't drink it. Would that include the grape?
Grapes?
Yes, as in red wine and white wine.
The unfermented grapes is okay.
Okay, good to know. Thank you. Dave, any thoughts?
Yeah, I mean, I agree with all of that. I think you've got to be very clear what is general health advice and what is advice specific to PBC. Okay, so for PBC specifically, what I would say is the only thing to be careful of is fat intolerance. So sometimes people can struggle with fat, get some abdominal pain from it, a bit of diarrhea. So watch your fat intake if you get that. In terms of general health advice, PBC isn't any different, and that is around, all the carbohydrate things. So a lot of people are moving towards a low carbohydrate input. I couldn't agree more about fructose. Fructose is all bad, and it's one of the reasons why I think there's a big problem in America, particularly with obesity, because they have a lot of fructose in soft drinks. So, but I wouldn't particularly advise against red meat or anything like that. So in terms of healthy lifestyle, really important to keep your exercise up. Okay, so that counterpoint is energy in and energy out. And so exercise, I think there's emerging evidence that it's good for people with PBC. It's good for your general health, good for your cardiac risk. It's good for your bones, and it's also very good for your fatigue. And the biggest problem is PBC patients feel that they struggle to get going with it, but it is part of a healthy lifestyle. And forgive me if this lady's on the call today, but in the clinic on Monday, I met a lady around about 60 who asked me if it was okay to continue boxing with her PBC. And I said, oh, you mean boxing exercise? And she said, no, boxing. I've had my 4th competitive bout. And I just said, that's a new one on me. But yeah, absolutely. And does full-on boxing training. And do you know what? Makes her feel really healthy. There you go.
Sorry, Brian. Thank you.
May I just add a brief comment?
Please.
I fully agree what Dave said. And I fully agree. It's 2 important things here. The message is you don't have to run a marathon.
Yes.
The smallest movement is good and healthy. It can be 10 minutes. That is really sufficient. It can be anaerobic and so on. It's not that we have to do, running for an hour or so that this is healthy. So every sports movements activity is good. But the second thing is, if you want to lose weight, then, you should not try to do that purely with more activity. 2 reasons: you need to run a lot to burn a lot of calories, and secondly, you have much more hunger after an activity, and then you re-award yourself by, now I've done some movement, swimming, cycling, whatever it is, and now I can eat a little bit more, drink a little bit more, and then the effect of losing weight is totally lost.
So Andreas, we in the foundation have a thing called movement as medicine, as a sort of concept for people, which is exactly what you've said, that keeping active, any activity is good for you. And I always say, when we talk about this, I asked a colleague who worked in exercise science, what does exercising mean? And he said, doing 10% more tomorrow than you did today. And I think that is exactly it. It's about fitting it into your ordinary life. So please don't take away the idea that you have to take up boxing. The point is, if that's what you want to do, then that's a good thing for you. It's about what you enjoy. And if you enjoy it, then you'll keep going at doing it much more.
Okay,
fully agree.
Okay, I have one more question in the quick fire round, and then we've got a question that's going to require a bigger answer. So the last one in the quick fire round is, I have gained weight since being diagnosed and have asked twice whether I should increase Ursa. On both calls, the consultant said my bloods are fine, so I don't need to increase. The Ursa calculator clearly states I should be on 1,000. I'm assuming that's 1,000 milligrams of Ursa per day and not 750. Can you advise what I should do?
If the lab values are completely normal, I think you're fine with the dose. Of course, we aim to use this 13 to 15 milligram per kilogram body weight. So if you weigh 50, 750 milligram would be just perfect. If you weigh 80, 75, you should rather go towards the 1,000 milligram. So I would not overtreat her if the lab values are normal. There's no necessity to go up to, let's say, more or less, arbitrary chosen dose we have used in the past, and somehow most studies have been done, and so we ended up with this dose. I would not try to overdose, go to 30 milligram per kilogram a day if my lab values are not normal. That would be not my recommendation, but I would not, now see the need to go up in this case.
And so Robert, wave the calculator.
Oh, I tidied up. I've tidied up my office. I need to go and get it. Right.
So one of the things that we did in the foundation was just to produce a really simple calculator. So you look at your body weight and we'll tell you the right dose. And it's just a simple thing. It's very useful. So, please get a hold of a copy of it. It's just helpful. I would agree with Andreas completely. The question, though, is, are your blood tests good or are they normal? And you remember, of course, in PBC, we have this slight gap where we accept a certain amount of abnormality as being okay. The direction of travel, there you go, the calculator, okay? The direction of travel is for normal to be what you're aiming for, not good, but normal. And if I was on less than the optimal dose and my blood tests were normal, I would be perfectly happy and do exactly as Andreas said. Don't go chasing the dose for any particular reason if your blood tests are normal. But if they are good but still abnormal, I would go up to the correct dose. I think the direction of travel is to get better control.
Okay, perfect. Thank you both. I'm actually going to break my promise because we've just had another question come in from Brazil, and it would be rude of me not to take the question. So here's the question. For those with PBC, is it important to do an MRCP at some point? I have 9 years of diagnosis. They're saying they don't need the exam. Their PBC is stage 1 periportal fibrosis. So again, we can't give specific medical advice, but what we can do is give general information. Who wants to take this?
This one, maybe one is probably worth us both answering because it was maybe slightly different for different practice. So for me, I would not do an MRCP automatically as part of PBC workup. We would do an ultrasound in everybody, and we would repeat the ultrasound if there was a significant change in the liver blood tests, because of the potential for gallstones and for scarring related to that. And so if there was a significant change and the ultrasound showed any dilation of the ducts, we would do an MRCP at that point. But it's quite difficult for us to get hold of MRCP, and I would not do it as a routine. The caveat with that is I have a particular thing about particularly men with AMA negative PBC, because that's a trap I've fallen into in the past. Men are only 10% of PBC, and AMA negative people are only 5% of PBC. So AMA negative men with PBC are very rare. In my experience, they've all got PSC, and that for them, the diagnostic test is an MRCP. But if you are a PBC patient, AMA positive, and it sounds like you've got a biopsy confirming PBC, and the blood tests are not unusual, I would not do an MRCP.
Okay, perfect. Andreas, thank you.
I fully agree. So if we have a workup for a, unclear cholestatic liver disease picture, I think an MRCP should be included. Otherwise, we don't do that. If we have the diagnosis of PBC, there is no need to do that, except for, let's say, you have colics, symptoms of biliary obstruction or whatever, then you would do or would add that. But what I always have a problem is that we have these advanced disease stages or cirrhotics, where then an MRCP is somewhere externally done, and then somebody of the radiology department tells me, well, that can be, sclerosing cholangitis. And this is a problem because in these advanced liver diseases, the scarring in the liver tissue may narrow some kind of these bile ducts, and then they may look like sclerosing cholangitis, and this is then somewhat misleading, and then people say, is that now PSC, is it now PBC? So that may be then rather a misleading investigation.
And one really important thing, don't ever have an ERCP for investigation of PBC related bloods. ERCP is the endoscopic version of it. That is a road to disaster. And so that should only ever be done in order to open up a narrowing in the bile duct. So still there are some places in the UK that do ERCPs. Just don't do it. MRCP. And if you can't have an MR because you've got a piece of metalwork somewhere, then question the need to have any form of investigation. Please don't ever have an ERCP unless you absolutely need to.
Brilliant, perfect. Thank you both very much. And I want to highlight this thing just before we go to the last question. You'll have heard today lots of, I completely agree with this. Now, yes, both gentlemen are relatively polite, but actually this is not in deference to each other. This is in deference to the fact that there is a huge amount of international collaboration and agreement on standards of care and the best possible treatment of PBC. So again, wherever you are in the world, there is hope that you're able to get the same access to care and treatments. And I wanted to highlight the international consensus that there is. because this is a huge part of what the PBC is trying to help come about and be part of.
Couldn't agree more. Couldn't agree more.
Okay, thank you both.
Fully agree.
Right, of all the last questions, I promise you this is the last question. Recently had a FibroScan score 4.7. Then went to Dr. Google, which we can talk about separately, and found information about early diagnosis. They also found information about being diagnosed at a younger age, and that means that PBC tends to be more aggressive and less likely to respond to medication. She's about to turn 45 in a few months. So again, what can we do to provide information for this particular patient?
Do you want me to have a crack?
Yes.
Okay, so FibroScan 4.5, great. That's early. That's really early disease. Okay, so FibroScan looks back. It tells you how much scarring has arisen before that point. And blood tests largely look forward because that's looking at what might happen in the future. So that's really good. There is no significant scarring present in your liver. And, if people are confident with the test and that's to do with the investigator, that's really good news. Looking forwards, you need to control the disease as best you possibly can. And that is about future risk. And that's all about being on Ursa and then looking at the biochemical tests at the end of a year's therapy on Ursa. And again, at 45, I would be looking for normal liver blood tests as my target with therapy. So if you have a FibroScan at 4.5 and you have normal biochemistry on treatment, and you don't have any symptoms, because that's an important element of all of this, then we will be seeing you once a year just to check everything is okay. But this is looking really good, and the message will be go out and live your life. The issue about young age is not about risk as such, it is risk of a risk. So the younger you are, and this is our data originally that showed this, the younger you are at presentation, the less likely you are to respond to treatment, and therefore the more likely you are going to need different treatments. But if you respond to treatment, you responded to treatment. So it's about the risk of not responding to treatment rather than the overall risk in the disease. And for that reason, we will pay extra attention to somebody, of this age, because you're going to want 40 years out of your liver, aren't you? And so make sure you do the details well. But a normal FibroScan, we use FibroScan mostly to reassure people essentially that the disease is very low risk. So very low risk disease, but do make sure you respond. So the backward looking is FibroScan, the forward looking is blood test, but don't forget symptoms. And if all of that is normal, welcome to the new world of PBC, which is something that is a condition that you can go away and forget about.
Yeah, perfect. Andreas, please.
I couldn't agree more. I mean, very, very nicely explained by Dave with this, looking into the past. I always tell my patients, you look into the starring, to the stars at night, you see what was the past. The light is very old, you see there, and that holds true here for the FibroScan as well. And I think the young age is important. If you have certain antibodies, GP210 and so on, we look at some additional risk factors and keep an eye on that, and keep also, at least at our center, this elastography, most likely once annually. Is that done when patients, even the very, mild cases, come once annually, in most cases, to our center, they get an elastography. And if any, changes occur, if that value rises despite maybe lab values being not so high, then this should be indicative. If this is a repetitive phenomenon, then this should hint maybe towards a more intensive therapy. But otherwise, I would be very happy with that result.
And just on FibroScan to say, it is a real step forward. It is a really important technology because it's real time, because it's part of build it into normal clinical practice. But it's an important but. Rogue results can occur with it, and they shouldn't, but they do. Anybody who's managed lots of people having FibroScans, it will happen. So if you do get a FibroScan value that is out of kilter with previous values, don't panic. then speak to your doctor about it. And what we would normally do is repeat it on a different day, usually with a different investigator. And it doesn't mean that somebody's gone from 4 to 20. That doesn't happen in PBC, so it's likely to be a rogue result. So don't take a step back. FibroScan is part of the picture, but it's only ever part of the picture.
Wonderful. Okay, thank you. Somebody with PBC with a MELD score of 10, would they be okay eating beef and pork?
Would they what?
Be okay eating beef and pork? Maybe not on the same plate, but
yes.
Okay.
Sure. Yeah.
Perfect. Okay, that was fine. I just had to sneak that one in. Right, Andreas, we will come back to you with a score out of 10. No, thank you so much for joining us. It's been absolutely fantastic. I love the joint approach. I love the fact that there is so much agreement across borders. And again, with PBC being a rare disease, I think that one of the things we try to do is focus on the world of PBC and bring the PBC community together. So to Dave and some Newcastle outpost, and to Andreas in the centre of the world that is Switzerland, thank you both very, very much today. Really, really great to see you both, and we are so appreciative for your time and expertise. So thank you.
Well, I thank you. It was
thank you everybody for your great questions as always.
Yeah, absolutely. That makes it so interactive and important. That is fantastic, and throughout the world. I mean, that is that's
we've gone from Australia to Europe to Alabama to Brazil.
Yeah, to South America. That's amazing. This is the big advantage of COVID, that these technologies have definitely advanced.
Absolutely. I mean, I think Robert totted up the number of different countries that have logged into this. I think it's 45 is the sort of total, and I couldn't agree more. COVID made us do this. We'll never stop doing this.
Yeah. Brilliant. Okay, we've all got meetings at 3:30, so thank you so much for your time. Enjoy the rest of the day. We'll speak soon. All the best.
All the best. Thank you.
Thank you.